Good day, and thank you for joining. I am Sherilyn Francis with the Georgia Health Information Technology Extension Center. The future of health IT is here. Turn it on. We invite you to connect with us at www.ga-hitec.org and via social media at Georgia HITEC using hashtag HIT Solutions. We thank you for attending today's webinar. Georgia HITEC is Georgia's only federal and state-endorsed expert to assist providers in the achievement of meaningful use of EHR technology. We are located at the Morehouse School of Medicine, National Center for Primary Care. I now present to you today's webinar entitled Meaningful Use Medicaid EHR Incentive Program 2017, presented by Phoebe Nelms and Ryan Spikes. In compliance with ACCME guidelines, the following speakers have no financial or other relationship with the manufacturers of any commercial service discussed in this educational activity. The objectives for today's webinar are to review and identify Medicaid EHR Incentive Program requirements, to identify meaningful use objectives and measures, to apply knowledge of measures and use of certified EHR technology in meeting reporting criteria, and to present reminders and tips for creating documentation. And we will begin today's presentation with a poll question. The question is there a difference between MIP and MIPS?
Thank you so much, Sherilyn. And we're looking forward to seeing your responses. Yes, this has caused quite a bit of confusion, and so we just wanted to clarify some things before we get into our main topic for today, which is how to be successful in doing the Medicaid EHR Incentive Program attestation for 2017. So looking at the responses, yes, there are two different programs. I don't know, overload. It's evenly split. Okay, so I'm glad we have a moment to cover this topic. Thanks for sharing your responses. MIP versus MIPS. What is the difference? So for those of us who have acronym overload, MIP is short for the Medicaid Incentive Program. And it's administered by the Georgia Department of Community Health, and it continues until 2021 for eligible professionals who are already enrolled in the program, because 2016 was the last year that you could enroll. And for completing the attestation, you'll utilize the GAMIS. Now, what is MIPS? MIPS is the Merit-Based Incentive Payment System, which is administered by CMS under the Quality Payment Program. And of course, you know that the Quality Payment Program is a result of the MACRA legislation. And its goal or objective is Medicare payment reform from fee-for-service to value-based reimbursement models. A little bit more on this subject. Medicaid providers who are only eligible to participate in the Medicaid EHR Incentive Program are not subject to the Medicare payment adjustments. However, if providers accept Medicare Part B payments, and they meet the volume threshold of rendering service to over 100 participants in Medicare Part B, or over $30,000 are billed for Medicare Part B patients, they should participate in both programs. So for Medicare, EPs will attest to the Advancing Care Information Performance category under MIPS, as well as the other categories of improvement activities and reporting on quality measures. And your level of participation will result in either a negative or a positive payment adjustment.
I would like to interject in saying that the MIP program remains optional. There is no penalty for not participating in the Medicaid program, even if you accept Medicaid payments. However, there is no incentive if you don't participate either. If you don't participate in the Medicare MIPS program, you will have a penalty if you meet the minimum value thresholds that Phoebe mentioned earlier.
Thank you so much, Ryan. There's another thing I would like to add. First-time EPs who have not done meaningful use successfully in prior years have until October 1st to apply for the one-time hardship exception if they're transitioning into MIPS for 2017. And this will allow them to avoid penalties from not attesting in 2016. And I encourage anyone who would like to learn more about this to visit qpp.cms.gov for details about the Quality Payment Program and its MIPS track. So now we're going to focus on what is actually needed to be successful in attesting to the Medicaid EHR Incentive Program for 2017. So we'll do a little overview. Eligible professionals, those who can be in this program: physicians, dentists, nurse practitioners, certified nurse midwives, physician assistants who lead at FQHC or an RHC. And the minimum patient volume threshold is 30%, with the exception of pediatricians who can meet a 20% patient volume for a reduced payment, either as individuals or as a practice group. So, with the Georgia Medicaid EHR Incentive Program, you attest to meaningful use through the MMIS or the MAPR portal. And this can be accessed through the link there. And you will need to have, this is very, very important, keep track of your registration ID from your CMS registration for the program, because you will need it to enter the MAPR portal. The additional documentation that is required by the state of Georgia. So that required documentation, you will have to have your meaningful use summary report or dashboard, which is generated by your EHR, along with your CQM measures. Now, to complete your patient volume calculator for the current program year, it is very helpful to use the figures that you calculate from your detailed encounter report. So you use the detailed encounter report to analyze your patient volumes, and then you enter the data that's required by the patient volume calculator using those numbers. You'll also need a verification of use letter from your EHR vendor. You'll need to complete your security risk assessment. Many have failed their audits because of not completing the security risk assessment. It's easy to overlook, but it is so vital. It's crucial to your success. You'll also need screenshots for yes/no measures that are taken during your attestation period to show that certain functionalities have been turned on in your EHR as evidence to what you're attesting to. And if you do take exclusions, you'll need to have documentation to support the exclusions that you've taken. And these documents have to be uploaded along with your application for the incentive payment. And it is highly recommended that you keep all documents, a digital file, plus print it out and keep a record of everything you've submitted for your attestation for 6 years from the date of attestation, just to be prepared in case there is an audit. Okay, so we have a little problem here. Straightening it out. So how long is our reporting period? These are helpful reminders and tips. It's 90 days. And you must have a certified 2014 certified edition of an EHR, and that will be confirmed when you ask your vendor for a verification of use letter. And the reporting period for your patient volume calculator should be the same 90-day period that you select to do your detailed encounter report. Because remember, one feeds into the other. What are the things that you need to capture on your detailed encounter report? Some of the rules are, it has to only reflect one encounter per patient per day. You'll need to capture the provider's name, the patient's name or a patient ID, the date the service was rendered, and the payer type, Medicaid fee-for-service, the CMOs, private pay, self-pay, so that you have a picture of your total patient volume, and then you'll be able to discern whether you have that 30% of Medicaid patient volume, which includes the CMOs. They really prefer that you upload this document as an Excel document. If you decide to upload it as a PDF, then you need to provide a summary list of all the payee types. So now we have another polling question for you. Just for emphasis, you should keep all documents plus a printout of attestation for how many years from your date of attestation? So this is very helpful because it does help you keep track of what you have turned in, and in case of an audit, you will be very prepared to answer any question that they might have for you.
I will add to this that in addition to the documentation that you upload, you should also print out a copy of your attestation. There you will have your registration ID, R&A number. For future years, that number does not change. You will also have answers that you gave to certain questions that are in the attestation portal on GAMIS.
Okay, we also want to remind you that you need to keep your certification number for your EHR because you'll need that while you're completing your attestation as well. And we'll get to that on the next screen. So, as we said, to be successful in your attestation, you need to have a 2014 certified EHR. And how do you know if your EHR is currently 2014 certified? Because occasionally, unfortunately, some vendors do lose their certification status. This website is extraordinarily helpful and very easy to use. So please make sure you take advantage of it and put in your EHR to make sure that it is certified. And just a note regarding future requirements on this issue. To meet Stage 3 requirements, all providers must use technology certified to the 2015 edition. And so there are a very, very few who are certified, and you can find out who those are. And it may even impact your future software choices going forward. So in 2018, all providers will be required to participate in Stage 3, regardless of their prior participation. And CMS hopes that moving all participants to a single stage of meaningful use will reduce the program's complexity and simplify reporting requirements.
I will add, towards the bottom of this slide, you will see that the information from this site is not sufficient to be used as a verification of use letter. And in some rare cases, when you gather a verification of use letter from your EHR vendor, the number on your letter may not match the number that you get from this site. If you get the number from this site and begin your application or your attestation in GAMIS and put in the number from this site and then get a different number on your vendor letter, you'll have to erase your entire attestation and start over. So this site is a great way to verify. Use it for a copy and paste, but please get your EHR letterhead verification of use letter prior to beginning your attestation in GAMIS.
That is an awesome tip. And by following it, people will avoid a lot of frustration. What are the objectives and measures? How have they changed going forward for Modified Stage 2 in 2017? So we'll just run through what the actual objectives are, and then we'll talk about them a little more specifically. So number one, we want to protect our patients' information. So that's objective number one, especially the ones that are housed electronically. And to do that, we'll do an SRA, Security Risk Analysis. That's the requirement. Number two, clinical decision support. Number three, computerized provider order entry. Number four, generate and transmit permissible prescriptions electronically. Number five, health information exchange. Number six, patient-specific education. Number seven, medication reconciliation. Number eight, patient electronic access. Number nine, secure electronic messaging. And 10, public health reporting. And so These objectives are found, of course, on the CMS website. There are 10 of them. Some have multiple measures, and all measures have to be met, unless, of course, you meet the exclusion. So, number 1, protect patient health information, and we do this by creating, it says protect electronic protected health information, EPHI, created or maintained by the Certified Electronic Health Record Technology through the implementation of appropriate technical capabilities. So, there is a security risk analysis tool, which is provided on the healthit.gov website. Also, there is a security risk analysis tip sheet, which can be found from CMS. Georgia HITEC also has a template, which we can share with you to guide your completion of your security risk analysis. And of course, this is a requirement for meaningful use, but it's also a requirement of the HIPAA security rule. And at least once each calendar year, providers or practice managers must conduct or review a security risk analysis of their electronic health record technology so that you can identify any security deficiencies that you might need to correct. And of course, it would be wise to do this if you're going through a new installation of new equipment or any software really that stores, transmits, or accesses your patient health information. And failure to conduct a security risk analysis, as mentioned before, is the number one reason for failing an audit. And as mentioned, the tip sheet is very helpful in providing an overview of the security risk assessment requirements, as well as giving you additional resources from the Department of Health and Human Services. For the state of Georgia, you are required to upload your security risk analysis along with your application, and of course keep all this documentation for at least 6 years from the date of attestation.
You do not have to use a security risk analysis tool or the Georgia HITEC tool. You are welcome to use any tool that you find or have a private company or person conduct the risk assessment for you. However, there is a rubric of requirements that you must have when you upload your security risk analysis, and you must identify the 3 parts: the technical, physical, and administrative securities. You must identify any risks that you found and have a mitigation plan for all of those risks. The rubric for evaluating an effective or acceptable security risk analysis is public, and you can reach out to your Georgia HITEC rep and we can share that with you, or you can follow up with DCH's webinars and they can help you also.
Wonderful tips, Ryan. Thank you so much. So then we'll move on to objective 2, using clinical decision support. Use clinical decision support to improve performance on high priority health conditions. So the measure states that a clinician should implement 5 clinical decision support interventions, and these should be related to 4 or more clinical quality measures at a relevant point in patient care for the entire EHR reporting period. And if you don't use or find 4 clinical quality measures that are related to your scope of practice or to your patient population, then they can be related to other high priority health conditions. So of course, and measure 2, let's get to measure 2. Make sure that you've enabled and implemented the functionality for drug-drug and drug allergy interaction checks for the entire reporting period. And of course, there's an exclusion if you write fewer than 100 medication orders during the reporting period.
Yes, you can exclude only measure 2. There is no exclusion for measure 1. And one thing I find that I think will come up in subsequent year audits, it may not come up when you turn in your attestation, but measure 1 matching to your clinical quality measures. If you turn in measures or clinical decision support rules that don't match your measures, and your measures do not have a 0 denominator, If they have a zero denominator, those clinical quality measures are not relevant to your practice. But if you turn in measures, let's say for instance you have a measure for childhood immunization for your clinical quality measures, and you're a pediatrician, so you have very high numbers for that measure, but you don't have a clinical decision support rule that matches or relates to childhood immunization, I feel that that could be a flag in future years once you're audited. So make sure you work with your Georgia HITEC rep to match those measures with your clinical decision support rules during your attestation period, not at the end of it, so that you have time to actually put those rules into place.
Excellent tip. And of course, clinical decision support is a tool, and it's a tool that's supposed to help providers cope with the overwhelming amount of information that's available to support patient care. And these clinical decision support rules may be reminders or order sets or condition-specific order sets, clinical guidelines, or focused data reports and summaries that are unique to the patient you're actually seeing. And so it's very important that we link the clinical decision support rules that we put in force with those quality measures. That was a great tip. And be sure that the functionality is turned on in your EHR to capture that you are doing a drug-drug and drug allergy interaction checks. Objective number 3.
Oh, I'm sorry. I'd like to interject that this is one of the ones, objective number 2, that you will need a screenshot during the attestation period. They look for the date at the bottom of the screenshot. Then they want it to be between any time, just one, during those 90 days.
That's right. Very good. So, objective number 3, computerized provider order entry. So this is where the physician would use their EHR to place orders for medications, laboratory and radiology orders, or anyone who is allowed to enter orders can do so. So there are 3 parts to this, 3 measures. So you would use, to satisfy these measures, you would have to have 60% of your medication orders created using CPOE, more than 30%, oh, that's very key. It's not just 60%, it's more than 60% of your medication orders, more than 30% of your laboratory orders, and more than 30% of radiology orders. And of course, there are exclusions if you do fewer than 100 medication lab or radiology orders during your reporting period. So this one has not proved to be very challenging. Most providers are on top of it. Objective 4, electronic prescribing. The objective is to generate and transmit permissible prescriptions electronically, and the measure requires that more than 50% of the permissible prescriptions written by the provider are queried for a drug formulary and transmitted electronically using their certified electronic health record technology. The exclusions can be met by writing fewer than 100 permissible prescriptions during the reporting period, or if you do not have a pharmacy within your organization or within 10 miles of your practice that can accept electronic prescriptions.
With objective 4, we started running into issues when the formulary became a requirement in 2015. Some EHRs require you click an extra box or take an extra step when writing a prescription in order to check the formulary. You have to verify this with your individual EHR. But if you were meeting this measure and all of a sudden you're not, it's usually the formulary that's the issue.
Awesome. Okay, great tip. Objective number 5, health information exchange. The objective reads, the clinician who transitions their patient to another setting of care or provider of care or refers their patient to another provider of care gives a summary care record for each transition of care or referral. And the measure states that an EP that transitions or refers their patient to another setting of care or provider of care must use certified electronic health record technology to create a summary of care record and also electronically transmit that summary to a receiving provider. And you should do that for more than 10% of your transitions of care and referrals. So the exclusion can be met if a provider transitions a patient less than 100 times during the reporting period. And the link below is to a helpful tip sheet from CMS regarding this measure. Now, this measure has been challenging.
It has been very challenging for a lot of providers. Most providers do meet the exclusion. That's the good news. However, primary care providers and pediatricians rarely meet this exclusion. In fact, when they turn in the exclusion, they have been challenged at the point of attestation as to why they don't have 100 referrals. We work with our partner, Georgia Direct, to help providers meet this measure. The biggest issue is the referee, the practice that's receiving the referral, being able to accept the electronic file in some way, shape, or form. We are working on this on both sides. I guarantee you Georgia-HITEC is on your side. We work with your referrals to try and accept these, they're called QRDA files, or whatever type of file your EHR sends out, so that your receiving provider can accept it or is willing to accept it. For now, we do have some that have to send referrals both ways, both electronically and via fax, just to make sure it's gotten, because we do not want any patients falling through the cracks while we're trying to get this together. But be patient with this measure, work with us, and we will work with you as hard as we can to get you to pass it.
Thank you so much. It's always good to have someone help you. Objective number 6, patient-specific education. So the objective is for clinicians to use clinically relevant information from their cert to identify patient-specific education resources and provide these resources to the patient. So the measure states that this patient-specific education resource should be identified by your cert, and it should be given to the patient for more than 10% of all unique patients with office visits seen by the EP during the EHR reporting period. So of course the exclusion would be if you had no office visits during the reporting period. So the patient-specific education resources do not have to be generated by the EHR. The patient's problem list, medication list, or laboratory test results are used by the EHR to identify educational resources to match that patient's needs. So the information may be provided through a patient portal, a link, or you can print it out and hand it to them, but it must be identified by the certified EHR and given to the patient prior to your attestation to meaningful use. Objective number 7, medication reconciliation. Objective states that the EP who receives a patient from another setting of care or provider of care or believes an encounter is relevant, they should perform medication reconciliation. And this should be performed, according to meet the measure, for more than 50% of the transitions of care in which the patient is transitioned into the care of the clinician.
The biggest issue we run into with this measure is that providers do not check that the patient is an incoming transition of care. Most providers do the medication reconciliation, and once we make the correction to properly identify them is a transition of care incoming to the practice per the proper EHR way. It depends on your EHR. It varies in every single one. Once we get it checked, then most providers find themselves at 100% on this measure.
Okay, that's good. And so medication reconciliation process, as you point out, really is very important. It's an important element of patient safety, especially when you have patients who have multiple pharmacies, many comorbidity factors, multiple healthcare providers, and creating an accurate medication list can really reduce medication errors because it captures a more complete and accurate list of the medications that a patient is taking, even those that are non-prescription or alternative medications. And by comparing this list with both documentation in the patient's medical record during an ambulatory care visit, as well as if the patient is admitted to or discharged from a hospital, it can really be very important to patient safety. Objective 8, electronic patient access. The objective states that you should provide patients with the ability to view online, download, and transmit their health information within 4 business days of the information being available to the provider. And so the measure states that you should, for more than 50% of all your unique patients seen during the reporting period, that you give them access to view online, download, and transmit to a third party their health information, subject, of course, to the provider's discretion to withhold certain information. For an EHR reporting period in 2017, more than 5% of unique patients seen by the EP during the EHR reporting period should be given the capability to look at their health information. So this is a change from the previous year. It's now 5% is the threshold that you have to meet in order to meet this measure.
We have had some challenge with this measure before it went up to 5%. And the Georgia HITEC rep has some very, very good tips for meeting this measure, and they're dependent on the type of practice you have, how many people you have in your front office, whether or not you take interns. So work with your rep. We can talk through it on an individualized level and determine what's the best way for you to engage your patients and get them using that portal, because eventually it will be much, much easier for your practice.
That's true. It's something that's going to be even more important going forward. So for objective number 9, secure electronic messaging, the objective is to use secure electronic messaging to communicate with patients on relevant health information. And you can meet this measure for more than 5% of your unique patients seen. Then you send a secure message using electronic messaging function of your EHR or to the patient directly or to their authorized representative. Or you can respond to a secure message sent by the patient or their representative during the EHR reporting period. And the exclusion, anyone who conducts 50% or more of their patient encounters in a county that does not have 50% or more of its housing units with 4 megabytes of broadband availability according to the latest information available from the FCC on the first day of the EHR reporting period. So this may apply in rural Georgia or someplace where they don't have a lot of broadband availability, but I've not come across this often.
I have not either. I have run into one provider that was able to take the FCC exclusion, and that was because most of their patients were across state lines. The provider was in Columbus, but most of their patients were across state lines in Alabama and didn't have access, didn't have the broadband. There was a lot of paperwork that we had to do to adequately prove that it was the patients that didn't have access to the broadband because the provider did. I would not rely on this exclusion. Even in rural Georgia, I would definitely try your best. And once you get your patients engaged in using the EHR like you have to do for the prior patient electronic access measure, then sending them a message, because the message has to come from the provider. Sending them a message won't be hard. You can send out a general message to remind your patients that it's flu season and they should come in and get their flu shots. It should be very easy to hit 5% sending it out. However, most EHRs will not count patients for this measure unless your patients have logged into the portal at least once. So even though you signed up 100% of your patients, if you aren't engaging them to log in and you send out a message, it will not send it to patients who have not already logged into the portal. So once you hit Objective 8, Measure 2, getting 5% of your patients to log into the portal, we can very easily in one day accomplish this measure together.
Excellent. Okay, so we're going to move on to objective number 10, public health reporting. The EP is in active engagement with a public health agency to submit electronic public health data from their EHR, except where prohibited and in accordance with applicable law and practice. So the measures you can connect with an immunization registry, be in active engagement with the public health agency to submit immunization data. Here in Georgia, that would be GRITS. Measure 2, syndromic surveillance reporting. This is not available presently in the state of Georgia. And so you would contact the Department of Public Health, and they require you to fill out a form, and the link to that is on the bottom of the slide. For Measure 3, specialized register reporting. The EP is in active engagement to submit data to a specialized registry.
This specialized registry has been a bit difficult for some of you. However, finding an exclusion because you're having difficulty finding a specialized registry is fairly easy, but it does require some very individualized assistance because your registry will depend on your specialty.
Okay. And so we did not list all of the exclusions on this measure because it is quite lengthy. But please feel free to go to the CMS website and look at all of these objective sheets in detail. And there are also tip sheets that are available for many of these measures. So we're going to just very briefly touch on the Stage 3 objectives because it is not very likely that many providers will be attesting to Stage 3 at this time. But many of the measures and objectives are the same with some increased flexibility. So the overview of Stage 3 objectives in 2018, all providers will be required to participate in Stage 3 regardless of their prior participation and should attest to Stage 3 in 2017 if you're able. And to meet the Stage 3 requirements, all providers must use technology that's certified to the 2015 edition. We'll see if they come out with some flexibility regarding this, but we'll have to wait and see. There are no alternative exclusions or specifications available in Stage 3. And so to find the actual specifications, please see the link, use the link, and please contact Georgia-HITEC for assistance if you'll be in Stage 3 in 2017. So that brings us to the end of the information we wanted to share with you today, and now we'd like to get your questions. As you have been entering them, I see quite a few. Ryan, can you see the questions?
Yeah, I can see the questions.
Okay.
We have a question here that says MIPS does apply to FQHCs, doesn't it? I guess. If you need more assistance about MIPS, please contact Georgia-HITEC. However, it does, yes, if you meet the Medicare requirements, I'm sorry. The information presented in this webinar is not specific to Georgia. However, A lot of our tips may, my webinar just blinked out. It's coming back. A lot of our tips may be specific to Georgia, but the information as far as the measures and the requirements for the objectives of the 10 measures, those are not specific to Georgia. Those are nationwide, and CMS sets those, and each state has to follow them. However, the information that we say that you need to upload, like the security risk assessment, your screenshots, that is specific to Georgia. Depending on other states, they have different requirements for what has to be turned in. Some states have patient volume calculators and some don't.
Okay. Alrighty, we have a question here. Clarify the details about the screenshot required for Measure 2. So
for Measure 2, I find the best screenshot to provide is the screenshot from your administration page where you set up your clinical decision support rules and your drug allergy interactions. Most of that is done under admin for most EHRs, but it does vary. And when you take the screenshot, capture the entire screen, make sure the date is visible at the bottom. The other screenshot you can use for that is real-time screenshots, which is if you have a provider that is working with a patient and once that screenshot comes up, you capture it at that moment. That is very difficult in the middle of patient care to do. It is also very difficult if you have multiple providers and the office manager is responsible for attestation of meaningful use, because that office manager is not there when that screenshot needs to be taken. But both are acceptable. If you need any more help or ask any more questions, please list.
Okay, so we have a question here. Sorry, missed the first few minutes. Year 4, what is the reporting period for me? The reporting period for everyone in Modified Stage 2 is 90 days. Do you have any tips on getting patients, especially child patients of pediatricians, enrolled and logged into the patient portal?
I will give you a couple tips. However, it is illegal under the age of 18 for a patient to have a portal. So the portals will have to go to the parents, and you will have to engage the parents in using them. And once the patient turns 18, because many pediatricians see patients through 21, once that patient turns 18, that portal disconnects from the parent and you have to set one up for the child. So while you may have an active parent on the portal, you have to do that again as soon as the child turns 18. With parents of children, it is best to engage them at the point of service, because once they leave and their children are there, their brains are not there anymore. They don't want to think about portals and emails and anything. So it is best to engage them either in the waiting room, when they first sign in, give them their portal login, and ask them to go on their phone and log in right then and there. Excuse me. If that's not working for your office, the MA can do it and encourage them to do it between the time they get the vitals and they're waiting for the doctor. It really depends on your patient workflow and how many extra hands you have in your office, because it does take about 3 minutes per patient to get them to log in, so you need to have that much time. And one of the things that works well with my pediatricians is they cannot do it at the point of service is some sort of an incentive. Listen, if you log into the portal, we'll enter you for a chance to win a $50 Visa gift card. And once you log in, you instantly get a record of who has used that portal. You can pull that in easily. And then that encourages the parents to go away from the practice and actually log in, because it's an entry for a gift card.
That's excellent. Great suggestions. There's also a resource on the CMS website, I think it is, the patient engagement handbook,
Mm-hmm.
which has lots of other tips. And if you really want to dive into, how to do this, you might be able to find some good points in there as well.
For the 90 days, can it be any 90 days or a specific days? It can be any 90 days as long as your EHR is able to pull a dashboard for that 90-day period.
So another question is, when will the system be open to accept submissions for 2017? The answer is, we do not know. So we have to await the announcement from DCH as to when that will occur.
We're expecting early September, I think. Last we heard, but there is no date.
So is it against Medicaid rules to incentivize patients to be engaged with the portal?
No.
No, sir. Repeat that regarding September. We don't know when the portal will be opened. This is something that is done by the administrator of the Medicaid Incentive Program in conjunction with CMS. So whenever Department of Community Health announces that the portal is open for accepting applications, that's when we will be able to pass that information on to you.
What if electronic transmission is just not available? This would be a very specific question. We'd have to know why, where you're located, what is causing it to not be available. I would suggest calling Georgia HITEC and getting a representative to help you personally.
So another question, does the volume calculator 90-day period need to be in the calendar year prior to the MU period?
No, the volume calculator and detailed encounter report 90-day period, which are the same period, they can either be prior calendar year or current attestation year, but they cannot cross, so you cannot do December, January, and February.
All right, so it has to be a 90-day period within the calendar year that you select. So you can use prior calendar year data or current year data, but they prefer that you use prior calendar year data so that your claims will be available for analysis. Well, this brings us to the end of the questions that we have received. It's been an absolute pleasure to be able to share this information with you, and Georgia HITEC looks forward to being of assistance to you in being successful in completing your attestation for meaningful use in the Medicaid EHR Incentive Program for 2017. We wish you all a wonderful afternoon, and thank you again for joining us.